Hello?
Marion, is that you?
That's me.
Hello, darling.
Oh, gosh. So, wait a minute. Let me click this. Are you there?
Yes, ma'am.
Okay. So right now I clicked the phone call, but when I'm on, am I clicking audio or phone call? Or does it not matter?
If you called in, it should be phone call. If you're on computer audio, you should be on computer audio.
Okay. So if
hi guys, I don't click either of those boxes.
Oh.
I just place, call. I get the dialog box on my screen, and then I just call in on the number that's listed.
Okay, because it's asking me to choose. So when I was on computer audio, I did hear you. So should I click on that and hang up to be sure?
Do you want to talk through your computer?
I think that's what I did last time. I'm not sure. What are you on the computer or you're on the phone?
I'm on the phone.
Okay, so I'll stay on the phone.
It's Marsha.
Hi,
Hey, Marsha.
How are you?
Hi.
Hey, Marsha, do you have any tips for Marion? She just had a technical question. Would you be able to answer it for her?
Maybe.
Okay, so right now I'm on the phone. I called in. It's asking me to choose computer audio or phone call, and I think it probably would sound better if I stay on as the phone call while I'm speaking.
Yes, definitely.
Okay.
Definitely.
All right, good.
Because the computer, you never know what's going to happen.
Oh, I know.
I was going to say,
I'm known to lose. And we're actually going to have a bad thunderstorm here, so hopefully I will not lose anything during the process.
No, no.
Hey, you know what? We'll just improvise.
Yeah.
It's disconnected.
Okay. So, Donna, since we haven't really spoken, I just want to clear. So I'm speaking on pages 17 to 23, correct?
I think that's right. Let me just double check. Yep.
Okay.
17.
Okay.
And I'll toss it to you. Like when I get done with slide 16, I'm going to say something like, okay, now Marion's going to take us through the first couple of steps of collaboration. Marion, I'll say something like that.
Okay. I'm just a little unsure of what to I have everything all written out here. On 21 to 23. I don't know, exactly what. Did you want me to say a whole lot about slide 22 or just more go into on 23 or just kind of combine the two?
I think, like, for example, on slide 21, you'd go, okay, now the second step really in collaboration and really working together with our partners in payer enrollment and credentialing, we have to understand what their needs are. And by doing that, we recognize, and then I'll go into the next slide. By doing that, it's important to understand all of the stakeholders that have influence in the work that we do. So the slide that you see on 22 addresses the practice managers. Being the physician is the nucleus, and all of these other people are the ones asking the physician for information. So if we, around that physician, can work together in a stronger way, then we're taking some of that burden from the physician. Did that help?
Yeah, sort of. It does. I mean, I wrote really quick, but
and if you
okay.
tee it up, Nicole and I will just backfill it. Okay.
Okay. All right.
Nicole, are you cool with that?
Yep.
Okay.
Thank you.
Donna, should I go ahead and make you the presenter?
I have my PowerPoint on my screen, so I'm ready.
Let's see, where is it?
Welcome back, by the way, Marcia. I'm sure you're very tired because you just got back last night, didn't you?
Yeah, I did. It was a
Where are you
whirlwind.
coming back from, Marcia?
I was in Phoenix, attending the MGMA Operations Conference, which was really good.
We had our HR director there.
Oh, really?
I wanted to go. I wasn't able to go because my choice is either MGMA or NAMS. And with my certification, I needed the NAMS. My company will not pay for both.
Oh, yeah.
And I'm lucky if this is going to be the last year that they'll pay for NAMS. I'm not sure, but we'll see.
Crazy.
I
Budgets
know.
get tight.
Yes, it is. It is. And this is a very stressful week for me because we're going through negotiations starting on Saturday.
Oh, no.
Yeah.
Yeah, that is stressful.
Marion, and
Yes?
the fact that you carved time out to do this webinar is just wonderful. So thank you for your.
Oh, I hope so. I mean, I'm not 100% ready, but I know that you guys will help if I need to.
Of course, that's what teamwork's about.
Exactly.
All right, shall I show my screen, Marcia, or just leave it alone for right now?
No, you can show it if you'd like, and that way we can make sure everything's working okay.
Okay. Okay.
Perfect.
You see, and there's no black lines or anything, right?
Looks good.
Okay. I did just edit this front slide because I wanted to make sure people understood this was the Dr. FBI. That's our branding for IntelliSoft, and I want to continue to reinforce that whenever.
Okay. Perfect.
And so when I'm going to say hi once Marcia passes the program over to me. I'll do a brief introduction. I'll say hi, and then Marion, I'm going to ask because your picture is the next one. I'm going to introduce you. So just kind of think of a couple brief things that you'd like to say. Usually people say things like, I'm so glad to be talking, working in practice management. I'm so glad to be able to share my knowledge about this subject or something to that effect. Or you can just say, hi everyone. Whatever.
Do whatever feels comfortable.
Okay. All right.
Just let your wonderfulness shine through the phone, girl.
Yep.
Oh, I'm trying.
It's all about growing.
Oh, and I am growing.
And we all have safety nets because Marcia's there for me and Nicole and you are there for me, so that's how it works.
And I don't know if you've noticed, but I now have a little bit of a new business, which we can talk about at some point.
Yeah.
When I sent you my updated bio. So I'll be happy to share information with you on that one.
Yeah, we'll have to carve out a time where you and I can just chat. That would be great.
Yes, definitely.
You wouldn't believe the whole team of retreat professionals, everybody's been modifying their positions. It's just been wonderful. Success story after success story.
Well, we each bring something positive to what we do. And we've learned a lot through the years. And, as I had told you a few times, my ultimate goal is to stay involved through after retirement, which is not anywhere near close. But, and I get nervous. Who knows what's going to happen with our renegotiations? I don't.
Right.
We'll see.
You always have to have a backup plan.
Absolutely.
Hey guys, I have you all on speakerphone right now, and these are new phones that I have throughout my office. So am I coming across clearly and loud enough?
Yes.
Okay, thank you. And just moments before we go on, I'm going to take, probably 2 minutes before we go live, I'm going to take it off speaker and I'll talk through the old-fashioned way, just because I've had experiences before when people use their speaker feature. Sometimes if they turn their head, their voice sort of fades. So I'll make sure, I go back to the normal way of conversing.
Perfect.
And you're going to activate the poll questions, right, Marcia?
Yes. Just indicate when.
Okay. And I will, now can everybody see the results, or is it just the speakers and you?
As long as their dialog box is open, they should be able to see it. Actually, I haven't done this in a while. I think it pops up.
Okay.
As I recall, I think it pops up in the middle of the presentation once I launch it.
Okay. And if I miss a perspective, Marion or Nicole, during those results, please feel free to interject, just like we always do, because sometimes I'm so focused on doing the operational pieces, I might conclude a finding from a survey result more just on the surface. So if you have a deeper perspective to offer, that's great.
Marcia, do we have any questions that were inputted during the registration process?
There was on the registration form. I'm not sure what the question was. I would have to, when I run the report, you'll see all the responses.
I bet it was, do I get NAM's credit for this?
Yeah.
Sometimes, oh my gosh, it's like people. Okay, I'm going to step away for a moment just to get my mind right. Now I'll be back with you in about a minute or so.
Okay. How are things with you, Nicole?
Oh my gosh. Everything's fine. We're actually gonna look at IntelliSoft.
Really?
Yeah. So I'm in a different position, and I was supposed to be only QA, but that I was only QA for like 3 weeks, and then the HR director said, Nicole is way more equipped to deal with this. I know nothing about this, and passed it to me in the middle of kind of a nightmare situation where the credentialing specialist had quit the Friday before the Tuesday it was passed to me.
Wow.
And so we're hiring, and I think we're going to be able to hire the lady that worked for me at Northwest Pathology. We're going to we've already gotten approval to implement a software system. The previous specialist had rolled out IntelliSoft, and I said, I don't think we should. I think that it was a closed-minded, what do we need now, not what do we need in the future. And we're going to go towards delegated credentialing because we have 48 different hospitals.
Oh, wow.
Yeah. So I'll be in touch with you guys. They also didn't look at Cactus or Simpler or any of the other big guys because they were looking specifically just to maintain what's happening versus like, what does it look like if we continue to grow 13% annually?
Right,
yeah. So that's my hope, is that, and that's that one side of, I guess, what I'm oversight over at the moment. So it's
so we use IntelliCred, and that's IntelliSoft. Is that correct?
Yep.
Yeah. Okay. I just wanted to make sure.
All right, ladies, I'm going to just prepare a couple things and get ready to start in about a minute.
Okay,
thanks,
I'm
Marcia.
ready.
Yes.
And you guys can hear me, right?
Yep. Yes, ma'am.
Okay.
All right, I'm going to start. Hello, everyone, and thank you for joining us today. My name is Marcia Wessel, and on behalf of IntelliSoft Group, I'd like to welcome you to the evolution of MSPs in practice management. The program today will be presented by Donna Gestencourt, Marian DeGolo, and Nicole Keller, and is brought to you in collaboration with Team Med Global and sponsored by the Massachusetts Association of Medical Staff Services. For those of you who may not know IntelliSoft Group, we are a leading provider of credentialing, provider enrollment, and contract management software. We also have an NCQA certified CVO division that can help with either temporary or full-time assistance for a number of services, including PSV and enrollment. A few housekeeping items. The dialog box located on the right-hand side of your screen is very helpful for a number of reasons. For instance, if you find it difficult to hear the presenter, you may want to call in on the telephone number displayed in the audio section of your dialog box because sometimes computer speakers aren't ideal for sound. Also, there will be a live Q&A at the end of the webinar. Because we have so many attendees, we request that you submit your questions in the question or chat section of the dialog box. Finally, the PowerPoint, Certificate of Participation, and NAM CEU for today's programs are available for download in the handout section of your dialog box. So you just click in there and you can download all three documents. Now it is with great pleasure that I introduce our friend and today's first speaker, Donna Gestencourt. With over 42 years experience in the medical staff services industry, many of you may know Donna or have worked with her personally. And with that, I'll turn things over to Donna.
Wonderful. Thank you, Marcia. Hello, everyone, and welcome to the first practice management session in our very successful Dr. FBI series. Throughout the year, IntelliSoft and Team Med Global will be presenting on a variety of educational webcasts targeting areas of greatest need within the industry: credentialing, payer enrollment, practice management, and career development, just to name a few. This educational variety pack will prove valuable to the professional development of all industry healthcare professionals, regardless of the environment in which you currently work. Now, today's program, Sign In and Checkout, will showcase areas of competence needed for those working in physician offices and the importance of collaborating with credentialing and payer enrollment specialists to improve all of our practices. My name is Donna Gestencourt, and I'm so pleased to be part of this trailblazing series, the first in the industry in collaboration with IntelliSoft Group, and along with my co-presenters, Marian and Nicole. Marian, I'm going to ask that you please give a shout out to the first-time listeners and our very loyal followers.
Good afternoon, everyone. My name is Marian DeGolo. I've been in the healthcare arena for over 30 years. I am currently serving as a practice administrator of a large anesthesia practice in Florida, and I am involved in this ever-changing role as a practice manager.
Great. Thank you, Marian. And Nicole, how about sharing your lovely energy with one of your warm and friendly greetings?
Hello, all. I am so excited to be here on this Tuesday afternoon with my wonderful colleagues, both presenting and joining us on the phone. Many of you guys might know me. I do present quite often with Donna. I have over 10 years of experience. I've done everything from hospital credentialing, privileging, and have spent the last 10 years in practice management, from primary care to pathology or ancillary services, in an administrative leadership role. And I'm so excited to share with you, but also grow from each and every one of you.
Perfect. All right. So our learning and education partners for this session and throughout the Dr. FBI series are Marcia and her IntelliSoft Group team, my colleagues at Team Med Global, and most importantly, every one of you. We are always listening to the voice of the MSP, and this is definitely a team effort filled with lots of passion. So what field of information will Marian, Nicole, and I be sharing with you today? And I'm going to pause for just a moment and ask my fellow speakers, if you're not on mute, if you could please put your lines on mute, because I am hearing papers ruffle, and we want to be as clear as possible so our listeners are not distracted by that. All right, so what kind of field information are we going to be sharing today? How collaboration is such a key component of success within the medical staff services industry, and how that can work, how working together can really improve our efficiencies. We will also help identify for you the specific credentialing documents that can be shared to speed up the turnaround time of applications, which will also result for you an aha moment. Hey, I didn't know that. And then we will guide you to apply these small changes to decrease your work, decrease the frequency of repeated requests to provide specific credentialing documents, and thereby eliminating frustrations among all of our key stakeholders, but in particular, where you're allowed to perform your work in a manner that frees physician burdens with administrative tasks so that you and they can truly focus on your work at hand, they in patient care, and us to streamline our administrative efforts. So let's get started getting to know more about you, because we as your educators, we want to be adjusting as we go from slide to slide some of our messaging, so it's really targeting our listeners today. So I'm going to ask Marcia to please activate our first polling question, and then can you please describe to our listeners how they can respond?
Yeah, you should be able to respond directly on your computer, and we can see that the polling is in progress.
Okay, so the first question is, where do you work? If it's a solo physician practice, you want to select A, multi-specialty, B, a single specialty group practice, C, a medical staff services department, D, and payer enrollment, E. And we'll take just a couple of more moments for responses. All right, so you tell me when we're going to close the ballot or close the survey.
I just closed it.
Okay, so solo physician practice. And I think this is really important, so it gives us all a baseline of who's participating on this educational webcast. Solo practice is 1% of our listeners. Multi-specialty is 24%. Single specialty group practice is 8%. Medical staff services department, 61%. And payer enrollment department, 22%. So really what I'm seeing, just based upon these results, what I'm seeing happening in the industry is those of us who've been in medical staff services departments for 10 years or more, they're wanting to expand their opportunities, and they are seeking out positions in physician practice groups. So I think that that's something as a correlation of why these types of webinars are so important, because we all have some expertise that we can share, and how we can make ourselves more marketable with transferring those transferable skills will make us even more valuable, not only in our professional development, but to our organizations. How about our second polling question, Marcia? Could you activate that, please?
Sure.
Okay, so this one's an easy one. It's either two options. Do you use credentialing software? A for yes and B for no. So that survey won't take quite as long to process. And you tell me when we're going to close it, Marcia.
I just closed it.
Okay, so 82% is a yes and 18% is no. And again, to all of our listeners, I know sometimes we think that everybody should be working with a software, but the reality just through this call tells us that there are colleagues who are working in different environments, who are working and managing all of their practitioner data, perhaps through an Access database or through or Word or Excel. So even though we may have been working with a credentialing software program for many years, there are still those in the industry who, gosh, have to do it kind of like the old-fashioned way. So we can certainly be sensitive and appreciate that. All right, and then our last survey question, please, Marcia. Do you frequently have to request or reproduce credentialing documents from others or for others? Meaning, do you have to make requests to people external, or do you get requests from external sources asking you to produce, as an example, a state license? So again, as that poll is finishing, again, it's an easy sneezy. I think we're about ready to close that one.
Yeah.
And so, yes, so that again is it validates the purpose of this particular webcast, because we want to help reduce that administrative burden to all of our colleagues, regardless, again, the environment that they're working in. So when it's all about collaboration and how we can identify what documents we can share with one another. All right, so we're going to go ahead and continue on with our program. So please allow me to move past these survey questions, and let's take kind of a deep breath, because now we're getting into the meat of the program. Now that we truly have been able to take a peek into who our listeners are, let's really prepare ourselves for those practice-altering aha moments. I didn't know that, but when we know better, we can do better. So with that, we're going to talk very briefly about competence. Everything in healthcare is about how we can perform our jobs and our scope of work in the most efficient and accurate manner possible. That includes physicians and nurses and advanced practice practitioners. Well, the same holds true for us as MSPs or payer enrollment specialists or practice managers. We have to understand that competence is the thing that's really going to drive us to excellence. And just as the slide said, you know, Webster defines competence as the quality of being able to adequately perform tasks through our judgment, our knowledge, and our skill. And that really defines our level of competence. And a quick measurement, something that TeamMed Global introduced close to 13 years ago, it really is how we can measure ourselves, the knowledge that we acquire, the skills that we practice every day, and how we as professionals are able to demonstrate how we use our knowledge and our skills. And everybody that I talk with throughout my 42-year career, when they tell me and share with me their successes, things that they wish they could have done a little bit better, or maybe even some failures, their examples have always fallen into three buckets. It's either relating to a skill that they're performing, some issue with regards to their interpersonal skills, and their ability to fine-tune and elevate their efficiencies and their effectiveness in both their skills and their ability to get along with others, that really drives their success within their careers. And then when we're talking about skills, we look at all of these items that are listed, ending in the term management, because even if we are responsible for perhaps one aspect, for example, in a CDO, one professional may be totally responsible for expirables, but they're still managing that process. So as you see from the slide that's before you, the two areas that we're really going to be focusing on today, although they might touch some of our other core competencies listed here, but it's really pertaining to practice management, front desk management, and truly how we as professionals can interact in the most effective manner with one another. So with that sort of foundation laying component of our webcast, now again, we're going to take it even deeper. And I'm going to ask Marion to begin describing for us the first two steps in really working and solidifying our collaboration. Marion?
Thank you, Donna. I'm now going to speak to the next few slides that focuses on who our stakeholders are, and there are many that serve a unique role in practice management. Webster defines a stakeholder as one who is involved in or affected by a course of action. On the next few slides, we will identify who these stakeholders are. They are our physicians, our non-physician practitioners, who would be identified as our allied health professionals, practice managers, the credentialing specialists, the payer enrollment specialists. In healthcare organizations, we have the Hospital Medical Staff Services Department. The credentialing specialist and payer enrollment specialist can often also be interacting with the Medical Staff Services Department, whether the physician is an employed physician in a hospital or part of a large healthcare organization. The managed care credentialing specialist and the payer enrollment specialist, again, for renewals for Medicare, Medicaid, and the various insurances enrollment.
And Marion, I'm sorry,
Go ahead.
Marion.
That's okay.
Before we move on, I really wanted to reinforce with our listeners, because there may be some of you thinking, gosh, I know who my stakeholders are. But when I'm out in the field interacting with physician groups and CBOs and medical staff services departments, as an example, I will ask that question of my colleagues. Sometimes, and it's really about maybe a 60-40 split, the majority of them are able to identify their core stakeholders, but about 40% of our colleagues, people in the field, they're outside of their physicians, as an example, or an administrator. They're not seeing the broad picture of how valuable being able to identify people who have an influence in the work we do really are. So that's why we really wanted to underscore the importance of making sure we frame the whole component of stakeholders, because we can succeed or fail based upon how we can work with these individuals. Thank you, Marion, for letting me say that.
And to add on to that, we have seen the evolution of various type of healthcare organizations over the past 10 years. It's not the same landscape 10 years ago as it is today. We're also seeing, to address the other, we're also seeing surgery centers acting more like hospitals, where they're contracting specialty groups into their organization, and they're accredited, and we are having to meet their needs as well. So we're constantly seeing this shift of who our stakeholders are. So I think it's very important to also acknowledge that you have to always take a pulse. How are you taking a pulse of the industry and making sure that you do understand your stakeholders, not only in the present, but also in the future?
Thank you, Nicole. And as you can see on the next slide, it identifies the various and numerous internal and external stakeholders. Payers are considered external stakeholders who provide input to an organization. Patients are part of a stakeholder group that pays for our healthcare system and are the end user. Our number one stakeholder is our hospital affiliates, as our physicians have privileges at the various hospitals. Our internal stakeholders are the targets of the efforts. Under recruitment, provider relations, and HR, the importance of that department, or those departments, I should say, as we bring on new providers in a practice, it all starts with HR and recruitment. Donna, do you have anything to add to the next slide?
I think the perspective here, the first slide that we showed would be just examples. And remember, your culture is going to create its own influencers and stakeholders. So the previous slide identified some suggested stakeholders regarding practice management. This one here describes those stakeholders, internal and external, based upon the credentialing specialist. So this would be a good baseline for you to kind of evaluate internally. Okay, in practice management, yes, but I might have some that I would delete from here or some that you might add. And having that visual really keeps it front and center to the importance of how you can work together and begin to reach out to these stakeholders. Marion, did you go ahead?
Oh, I'm sorry. So, we've touched a lot on external stakeholders, but I want to reiterate the fact that internal stakeholders are as important as external stakeholders. Internal stakeholders like IT, risk, quality, contracting, they are the gatekeeper to certain information or services that either support us in a positive way or not so much support us. So I think we need to take an assessment of both external and internal stakeholders and understand how they can positively impact the work that we do.
Thank you, Nicole. On the next couple of slides, we'll touch upon the needs and wants of the stakeholder. We need to understand the roles of each partner as we all work together to assist the physician. As you see from this next slide, the physician is in the center as he is the main stakeholder. On the medical staff office, when the physician applies for staffing privileges and maintaining their privileges. The practice manager, who is responsible for the physician's operational management of the practice, the operational policies and procedures, billing, compliance, etc. On the payer enrollment piece, they are responsible to assure that the physician is on each of the insurance plans that he or she needs to be on and maintain those enrollments on an ongoing basis. On this next slide, under practice management, as a practice manager, we always look to see for well-organized, legible forms that come into our office for the physician to be able to complete. We ask for clear instructions when the deadline is. But as a healthcare organization, they expect to receive fully completed documentation, meaning if there are blanks left on the applications, it could be returned to the physician. They need to ensure that it's all legible, signed, dated, submitted timely in order for the physician to be able to go through the credentialing system. There's ongoing partnership between the practice and the various healthcare organizations on an ongoing basis. Next slide, please.
Was this going to be your last component that you're going to be addressing here, Marion? And then we'll roll this over to Nicole for what you need?
Yes, thank you.
Okay, you bet. Nicole, how about you take it from point 3?
I'd love to. So what do you need as a practice manager or administrator and or a credentialing specialist in a hospital? What are these credentialing elements? Donna does a really great presentation on these credentialing elements, and it's very thorough. But medical staff applications. If our providers in our medical group are going to provide services in a hospital setting, we need a medical staff application for privileging and credentialing. We need education. Is our provider educated? And typically that education then goes into postgraduate training and then board certification. We do have rules and restrictions about, whether or not we can onboard a provider without a board certification with a 5-year time frame, et cetera, that our accreditation body govern. Licensures is another thing. Sanctions against license is something that both practice managers and credentialing staff within a hospital setting are required to monitor. Professional liability from both the credentialing specialist in a hospital and also a practice administrator, something that you might not see from a credentialing specialist perspective in a hospital is professional liability. I said that incorrectly. Malpractice is something that we all require. Professional liability is something that within a medical group we do require. Hospitals also, if we are leasing space or have a service agreement with a hospital, they actually require proof of professional liability as well. We both dive into the malpractice history, understanding not only that they're covered, but what has happened in the past. Work history is also very important to both groups. And current clinical competency, and that will look differently depending on what type of privileges they're requesting in the hospital setting versus what are they actually providing for that group. Next
and
slide,
Nicole,
Donna.
before I advance, I do want to say again to our listeners, when I'm talking to those individuals, those professionals working in a physician's office, when I point out to them the things, meaning these elements, the documents that are needed by the Medical Staff Services Department, they're kind of blown away. Oh my gosh, I didn't know that they were needing all of these things. It just seems like a lot of times they keep calling me, asking me for this document on a practitioner and this document on a practitioner. So packaging it this way is really an educational tool, and that's how it serves those working in the practice management setting, just to have a baseline of the different documents and documentation that's required from a medical staff services or a CBO's perspective. Did that help, Nicole, as well, clarifying that?
Yeah, I think it's really great to acknowledge, especially with one of those poll questions, is we are seeing seasoned MSPs from the hospital setting coming into a practice group and actually providing an assessment on what the hospitals are in need of, right? Not only from an experiential point of view, but they might come into a practice where they're working with hospitals they're not experienced with, and asking the question, here are the things that we need. How can we ask this from our providers one time when we onboard it into our group? And I think that taking a step back, identifying all the elements that all your hospital affiliates need within a practice group setting, whether you're the administrator, you're a specialist, credentialing specialist, or payer enrollment specialist, and actually setting that as the onboarding checklist for the provider is really critical. And we can do the same thing with payers as well. And payers get a little bit complicated, and I know that you and Dina in your series touch on this a little bit, because oftentimes we bill based off group NPI versus individual NPI, but we have to enroll the individual to link them to the group. And so there's a lot of information that is needed from a provider. And oftentimes, if we do not streamline our process and we don't understand what our stakeholders need across the industry, payers and our hospitals and our other stakeholders, we're asking physicians for information multiple times and oftentimes the same information. So to go on to additional credentialing elements, the sanctions from Medicare and Medicaid, disciplinary actions in addition to monitoring other sanctions like the OIG, EPLS, DEA, state control substance, ability to perform, so FPPE. So when you onboard a physician, how do you, as a medical group practice, assess their competency, and then how do you manage that with OPPE going forward? And we do, from a practice group perspective, we do quality measures within our practices to identify the ability for our physicians not only perform today, but to make sure that they can perform in the future. medical staff membership affiliations, clinical privilege history. We do want to know what providers have done in past hospitals and who they've been affiliated with. That's a part of kind of our investigation into their past and whether or not they've provided great care and their behavior was sufficient or good at these other entities. The NPDB, or the National Practitioner Data Bank. As an HR person in the past, we do run criminal background checks. I know that whether they're employed or contracted physicians within a medical group setting, that's something that you may or may not choose to do. And the bottom line is all this information and all this data that we're gathering is basically to make sure that we can identify that they are who they say they are. And we also require, driver's license or passports, social security cards from an HR perspective if they're employed by our group, etc. And then we also have documentation, ROI, release of information, and authorization that they acknowledge that what they're providing to us is accurate information about their past. So another key thing that we all do, and oftentimes during the onboarding process, whether or not that is at a hospital setting or a practice group, is we do require peer references. We do require CME documentations. Also, from a practice group management perspective, we also require SAMs. Which is a part of the documentation, or it's an assessment of a CME or education. So kind of a written test, or at least an assessment of what they gain from the presentation, because that's required for maintenance of certification of their boards. And so that's something we track internally from a practice group perspective, is CMEs and SAMs. We also require case log. For example, I've been a part of a lot of practices that are ancillary services to hospitals, and their EMR system might not actually have a great case count of the work that they're actually doing for the patients of that facility. And so that is something that we do manage internally. We also look at, these large health systems where a provider might be required, depending on what his or her subspecialty is, only once or twice a year. Well, from a medical staff perspective, and going back into my days and putting on my medical staff hat, one case does not show me sufficiency, or is not sufficient to show me the quality of work that provider can do. And so oftentimes we are providing, as a practice, complete case logs for a provider without any patient identifications, but saying this provider performed maybe one of these type of cases in your hospital, but has performed hundreds throughout the year, and with this level of quality. Notification of decision to practitioner. So we all notify them when something, whether they get a license, whether they become a member of a medical staff and privileges. We do notify them of the decisions of all of these various stakeholders that we correspond with on a daily, weekly basis. And then the other thing to note is that both from a hospital perspective, and I would even say a payer enrollment perspective, in addition to medical group, we do onboard and we do offboard our physicians. At times are changing. Marion and Donna both identified the fact that there is an evolution happening. I remember times where a provider would come into a medical group and or a hospital and stay there their whole entire careers. And you saw that as you onboarded them from a medical staff perspective or a practice perspective. We're now seeing where a lot of even mid-aged, mid-practice physicians or allied health professionals are coming in already with 3 or 4 practices. And that's not necessarily a choice. We see a lot of mergers and acquisitions in our industry at the moment where the practitioner actually didn't change practice, but that practice was acquired or it merged with a bigger entity. And so that does complicate our work history verifications. That does complicate our affiliation, our verifications as we move forward as colleagues in this industry. So moving on to the next slide, identifying documents to share. I think this is key from someone who has worked in both a hospital setting and also a practice setting. If you click again, Donna, I think, yeah. So things that we can share the education, and that includes the PG years or the postgraduate years. We can share board certifications and licenses. We can also share work history. I think from a practice management perspective, I do believe that we need to be the ones that identify the contact individuals for each practice that a physician has worked at and make sure that that contact information, email, name, title, etc., phone number is current. Also, how do we actually share, kind of like what I was discussing on the previous slide, is how do we share, especially for our rural hospitals, the competency of practitioners, because once again, one case does not demonstrate the capabilities of a physician that's reading hundreds of cases per year.
Nicole, I'm sorry. I was going to call you a whole different name. I'm so sorry. Donna again. I want to make sure that, again, our listeners understand that when we're illustrating the documents that practice managers have available, this may expedite some of the documentation that those of us sitting in other environments may need, but it doesn't preclude us, those of us in medical staff services or at a CVO, conducting that original source. This does not replace original source information, but if you're missing an item to get that application through, knowing that physician's office can produce that document, sometimes is that bridge until that final document comes through. Culturally, you all have to decide with your medical staff what you all deem appropriate or through your policies. But again, rather than continuing to bother the doctor for specific documents, what these next several slides illustrate is that this documentation is already being collected and available in that physician's office.
Right, and we understand the reason behind primary source verification. We understand not only the reason from an accreditation perspective, but also the fact that that's something that might be in policies and procedures within our external stakeholders, rules and regulations, et cetera, governing documents of their hospitals. But like you said, we can help support obtaining that information. So for example, if one of our hospital colleagues is having a difficult time connecting with a peer reference or connecting with a practice administrator at a previous practice, why not have the credentialing specialist within the group practice help connect that administrator with that hospital credentialing specialist? And we can do that. We've also done where we've ordered AMA reports and sent them straight to the hospital if there is a need for that. Or the NPDB, they give you 2 reports. We typically save one sealed, and some hospitals, as long as they're sealed, and they're not open, will accept that. And of course, there's a date or a time frame that they will accept that. Once again, I think it's encouraging for me to know that we need to step outside of what we've historically done and ask, why have we done it this way? And if there's any kind of room to collaborate or share, I think we should try to research or go down that path until we kind of hit a wall, whether that's our accreditation bodies or our policies or procedures. Yeah. continuing with what does practice managers have? Like I said before, we are required to record and maintain Medicare and Medicaid sanctions. We do OIG ETLS. We do heavily monitor not only our DEA, but also, like I said, licenses. So anything that's certified or a license, we monitor very closely internally in a medical practice. The ability to perform, I am sitting around over 4,000 pieces of data that actually needs to be entered because we heavily monitor the ability of our practitioners to perform. And that's not only at the hospital in which some credentialing specialist might work, but all of the patients that we serve, whether that's inpatient or outpatient. Medical staff membership and affiliation. So if our provider is credentialed at 42, 48 hospitals, we know all of them, we know all the contacts. So once again, going back to work history verification, if a individual or a stakeholder is having issues connecting with a specific medical staff credentialing specialist in a different facility, we would be a great resource to tap and have us actually connect the two parties that need to conversate about a practitioner. We do ongoing monitor of the MPDB, criminal background checks and identity, and we do keep a constant up-to-date ROI or release of information on file for all of our practitioners.
You know, Nicole, something just hit me. Would it be necessary, so for you and Marion as examples, working in a practice management setting, if any of these items that we have arrows next to that the medical staff department may need in order to just facilitate a gap of a missing document, would you require that the doctor sign a release of information?
Well, typically we're the ones shepherding that application to the facility, and within most applications for hospitals, there is an ROI, a release of information included.
Okay.
And so, but yes, we would. We're not going to give information about our doctors unless we do have some sort of ROI on file saying that it's okay for us. Oftentimes, if we do not have an ROI or there's something, or we haven't been involved in a process that a physician is doing, for example, if they're moonlighting and they haven't really notified us, or if it hasn't gotten to certain departments, they will reach out to us and provide us contact information. And via that email documentation, the provider authorizing us to speak to informally via email, we'll keep that documentation on file to make sure that if the provider ever goes back and says, why did you reach out to Donna? Well, you know, in this email, you gave me permission to provide X, Y, and Z to this external stakeholder.
And I think the practice would be similar to a medical staff department. When we get requests for some item that perhaps is in a credentials file, unless it's confidential, we require that the requester produce a signed release from the physician. So I think, again, it's mutual courtesy and understanding what your policies are saying.
And going back to the physician, you know, it's the physician's information. It's not the credentialing specialist, whether it's in a practice group or a hospital, right? It's really the practitioner's information, and being respectful of that and being mindful. Yeah. So last little section here, once again, I think I articulated this fairly well in previous slides, but we are very rigorous in a practice group about CME and SAM documentation and also case log. Once again, it is really on our provider shoulders to demonstrate their competency and the work that they do every day. And so that's something that we are very diligent about within a practice group setting. And then to kind of hit this home, we understand as presenters, as practice managers or administrators, that we understand that you guys have to, as payer enrollment specialists and or credentialing specialists in a hospital, that primary service verification is a consideration, and that we understand the reason behind it, and it's a good reason behind it. I think the sharing piece of this is, if the breadcrumbs run out and you can't find the information you need to complete your processes, using your colleagues across the pond or in a practice group setting is key to expediting credentialing, whether it's in a payer enrollment setting or a hospital setting. And also, which is my passion, is reducing the administrative burden on our practitioners, really kind of fleshing through as colleagues how we best support them, and how do we keep them working for our patients and not working with paperwork. So the next slide is basically sharing is caring. I don't know, Donna didn't know who the Care Bears were, but the Care Bear stare, caring is sharing. And that's something we need to do more of, especially as our healthcare system becomes more complicated and documentation is required from various stakeholders. How do we share? How do we care about our physicians enough to kind of reduce that administrative piece from them? The bottom line is, guess who's driving population health? It's the physicians, but it's us as a team that's driving population health. And so we are sharing the end goal, which is providing outstanding care to the patients that we serve. So our destinies are the same, and we are colleagues, and we should be working together collaboratively and streamlined to best support basically the practitioners, but more importantly, the patients that we serve. We need to be organized around a clear mission, and I always go back to the patients, and I'm sure that anyone in healthcare, we're in healthcare because of the patients. So how do we make sure that our practitioners are spending more time with patients and less time with administrative documentation requests and needs from various stakeholders? We do have a common value, I hope, is population health, and that's one individual at a time. And a unified vision of the future. Once again, all of us are being asked to do more with less. So how do we streamline? How do we come together as colleagues across various organizations, understanding the boundaries that we do have in an organized fashion to provide the best support to our practitioners as we possibly can. And I think we are seeing that through NAMS and other entities of us, all of us coming together and really being mindful about not duplicating work and really supporting one another, even if we're not technically on the same team underneath the same facility. Next slide. Shared decision making. I have a really great example of this. Is we had a terrible situation with one of our practitioners where it was a life or death, and he actually came out of it. And what we did, instead of having an FPPE reintroducing him to the practice of medicine and really making an assessment from various different settings, we came together with all of our colleagues and said, what do we all need to make sure that this practitioner, when he comes back into this community, into our hospitals, he's a part of panels within payer organizations. What do we need to know to make sure that he is functioning at the highest level, that he's meeting the bar, the highest level that we can provide for our patients? And we did that as a collaborative effort. Improve the health of the population. Donna and I talk about this in other presentations about how we are moving away from paid per procedure or pay for service or fee for service, and pay for performance. And what payers are wanting to see, whether they are commercial payers or there are government payers like Medicare, they want to see population health. They want to see that the quality of care for the patients that they have on these providers panels are getting top-notch care based off best practice and research. And so that's something that we're going to have to continue to focus on, is the health of not only the individuals we serve, but the population in which we serve. We need to be mindful about the fact that technology is driving enhancement of care. With that being said, there's a lot of technology out there, but there is not data to support that it actually increases the quality of a patient's life and or the longevity of a patient's life. And so really understanding, going back to the quality of care that we provide in this new age of technology. And basically what we want to do, and I think we've kind of beat this over the head a little bit during this presentation, is we do want to reduce the cost and administrative work. I don't want to be doing the same thing as 20 of my colleagues are doing if it's not required, if it is not mandatory. So how do we reduce our own workloads because we're still being asked to do more with less? And therefore reducing the administrative work that our practitioners are feeling. And as everyone knows, and I think that the whole industry is kind of, the white flag is up for physicians as far as physician burnout. They're feeling it. They're feeling burned out. How do we keep our practitioners in a healthy, well state to provide incredible care to our patients? And at the end of the day, we also want to maximize reimbursement. If we are not getting paid for the services that we are providing, we will not stay alive. And so it's not about the money piece of it as much as it is keeping our practices open, keeping our practices high functioning, providing high quality of care so that we can serve the populations that we are connected to. If we do not receive if we do not maximize our reimbursements, our money decreases, our financial stability decreases, and therefore we either have to move out of certain communities and or we reduce the level in which we can serve. So we might have 10 different subspecialty specialists in for example, pathology. But if we can't keep those practitioners employed because we don't have the financial stability to do so, we're reducing the services available and the subspecialties available to the patients in the communities we serve. So I know that we struggle with that, healthcare is a business now. It is all about the money. And I would like to push back on that and say, it's not about the money. It's about keeping our medical groups open. It's about keeping our hospitals open. And that does require money because infrastructure and providers and staff require a financial investment.
All right.
So that's kind of deep. I'm going to pass this over to Donna because she'll just knock this out of the park as far as what do we mean? Where do we need to go? So thanks, Donna.
You bet. And I'm going to just take a pause here for a moment because I really want our listeners to kind of catch up. This is a lot of information that we've shared. In Telesoft Group and Team Med Global, this is our very first practice management program. And where we really want to take this home is talk to you as our professional colleagues. Just like physicians are getting burned out, my MSP colleagues, the payer enrollment specialists, and the practice managers, we're all feeling that pinch and that pain as well. And when I am out in the field and I'm speaking before organizations, local chapters, state organizations, and even at the NAMS conferences, I will frequently ask what the makeup of the audience is. And just as described by Marion and Nicole, the diversity within our organizations, within our industry, it's continuing to expand. We're getting more and more hands raised when we're asking how many of you belong to practice some type of a practice management association? How many of you are payer enrollment, are involved in payer enrollment, or do onboarding, or quality, or medical staff services? So this component, this window of information is spoken to you as the MSP professional. And finding that golden thread of tapestry that connects us all regardless of our environment, the logical thing that my co-presenters and I concluded is that we have to identify the thing that brings us all together, and that is credentialing. So what we learned through collaboration in today's session are the 25 elements that are required in the credentialing process. But of those 25, those things that we might be missing to kind of just not have it as an official, necessarily an official document, but to fill the gap, to help us know that, yes, that verification from that original source can be there, how we can help each other from the payer side, from the practice side, and from the medical staff department side, how we can really begin to think of our credentialing documents in a different way. So our suggestion is to identify those stakeholders. If you're in a practice management setting, reach out to your medical staff services colleague and say, okay, I just got a reapplication on the doctors in my group. Let's work together in helping to streamline the information that you are needing. Help me understand what it is you need and why you need it. And it's amazing as I carry this message forward in the field that people have the bonding that used to be very siloed functions. The bonding among these colleagues is becoming stronger and stronger. And that's really what the purpose of this program was, is to let those practice management professionals know that they're not alone, that we as credentialing professionals and payer professionals, we have needs as well. So let's just work together. And that's really what this power thought describes, right? When we work together, there's strength there. When we truly have teamwork in trying to accomplish our individual goals, so many wonderful things can be achieved. And the beauty of it is it makes our lives much more administratively free, where the physicians and those clinical professionals can truly focus on the care of patients. And that's really what this maiden voyage of practice management was meant to serve. So myself and Nicole and Marion, we do ask that, because we just touched the surface of practice management, there's a lot of depth in this area of specialty. So if you have a specific need or question that you would like for us to incorporate into our future programs for practice management, please just enter it in the dialog box in our post-program statistics. That information will be made available to us, and we'll be sure to incorporate those components into future programs that we're delivering. So with that, I'm going to conclude and ask Marcia if she could open up the floor for any questions that she may have received.
I am back, Donna, and so far we don't have any questions. I'll give it a minute. And in the meantime, I just want to remind everybody that in the dialog box on the right-hand side of your screen, in the handout section, we have the PowerPoint, the NAM CEU, and Certificate of Participation in there for you. So you can go in and download those 3 items and print them out or save them to your laptop. It looks like we don't have any questions today, which is interesting.
Well, and I know it's new information, so I think people just kind of have to absorb it, right?
Lots going on, a lot of moving parts.
For sure. All right. Well, I think that will conclude the presenters portion. Marcia, you want to take it away and close us out?
Sure. I just want to say thank you, Donna. Thank you, Marion. And thank you, Nicole, for today's very informative presentation. And thanks to everyone for joining us. Have a great day, everyone, and goodbye.
Okay. Thank you.
Bye.